All of this hardware is finding our way into our practices, and while cone beam CT is commonplace in most communities, intraoral scanning is becoming more common in larger numbers of practices. We tend to forget the simple things like digital photography that are so important to the comprehensive record of our patients. Functional digital records like TEC scan, for example, are also very important when delivering comprehensive care to our patients and being able to follow the outcomes of therapy over a number of years. When we have this digital patient, we actually gain several advantages. You see, digital technology enforces documentation. It permits the iterative improvement in planning because there's nothing expensive or time-consuming about removing a tooth and putting a different tooth on, or having 6 anterior teeth displayed that I don't like the form or the texture of, and I just replace it with a different tooth library. Or changing the vertical dimension in a denture occlusion, or for today's example, moving the location of an implant 7 times till I decide that that's exactly the place I'd like to place it. Digital technology enables precision in action, and we're going to talk about the value of guided surgery as we move through the lecture. And of course, the part that we all appreciate is that digital technology provides manufacturing fidelity. You know, it's absolutely clear that you understand that nothing in dentistry should be cast today. Anybody casting anything is missing the opportunity to really improve the quality of care. It doesn't mean everything is ceramic. You have to recognize that we can selectively sinter metals in a variety of forms today to make even better restorations than we could before. So biology has to drive our technological solutions. It's nice to have a whole bunch of technology, but there's nothing this technology can do to change or alter the rules of biology. So how do we make them work? What I need to do is share with you a story that's based on my understanding of extraction site management and tooth placement. It's not my goal today to teach people the method by which you see single tooth implants being performed here, but there are many steps along the way which have been informed by data regarding the biology of wound healing in this site, the biology of osseointegration in this site, and the biology of peri-implant mucositis in this region. You see, we learned a long time ago that there's a very specific place one places an implant in a socket, and that is palatally away from the buccal plate of bone. So as these new surfaces with improved implant osseointegration are placed in the socket, it allows bone to heal much more rapidly than bone resorbs. And that's a very critical point. If the implant is up against this buccal plate of bone in this incorrect position shown here, nothing but resorption can follow. Now, when we started asking about what is the condition of the interproximal bone prior to implant placement, we learned that, you know, clinical observations were one thing, and we could easily observe where the bone was clinically and using cone beam CT. Turns out it wasn't investigated in great detail. We also know that the level of the connective tissue attachment can be demonstrated clinically and estimated radiographically. And so when we see there is a loss in connective tissue attachment at the tooth adjacent to the implant site, we try to augment this. The reality is when there's more than 1 or 2 millimeters of connective tissue attachment loss at the adjacent tooth, we do not yet have a solution in our therapeutic protocols. And we often find ourselves very frustrated trying to regenerate this tissue. What this means is that despite all technology, there is an architecture or a foundation for local tissue health. And the architecture is really acknowledging the reality of alveolar ridge resorption, acknowledging that ridges don't get better when we place implants, that there are implant-related changes in tissue architecture that our lab has measured. For example, we now know that even healed ridges show resorption after implants are placed in the apical half of a dental implant. And then we have very little knowledge regarding peri-implant mucosa healing. And we still do not know how to improve that outcome, and we still do not know how to predict the outcomes above the level of bone. What is becoming very clear is the old adage that you've heard so often, which is, tissue is the issue, but bone sets the tone, is being questioned by the new data. And this is because of biology. You see, it's hard to predict what a group of thousands of patients will do in regard to one therapy because of the remarkable diversity in the patients. The genetics of every individual can actually influence wound healing. And these fundamentals of wound healing are very clear to us as biologists, but we don't quite understand how the interplay of biofilm and biofilm-mediated inflammation can affect this. What I will dare to tell you or suggest is that in the absence of inflammation, most of us human beings heal the same way. It is inflammation that is the key variable. In addition to local biofilm-mediated inflammation, we have systemic disease. And one important thing to remember, especially about the field of implant dentistry, ladies and gentlemen, is that the data that was generated by people like Dr. P.I. Brånemark in the late 1970s and early 1980s was generated using a population of people who do not exist anymore. I don't mean by that that they're dead and they're gone. What I mean by that is they're not the same. An example is diabetes. The incidence of type 2 diabetes in the United States is going up 13% a year. And presently, approximately 10% of our population has type 2 diabetes, and it may be more than that. That means that there is a large percentage of the population of patients who are entering your office for dental implants who don't have the same opportunity for healing as where we got that data that said we had 95% success. Very important point. And then superimpose behaviors like smoking and oral hygiene, and now you've got a periodontitis patient who's a smoker who has type 2 diabetes. I refer those patients.